Hello, everyone, and thank you for joining us this evening, for week 7 of the Rugby Research and Injury Prevention Group 2025 lecture summer series. My name is William McIntyre, and I'm a rising senior at Howard University studying sports medicine. We're going to start tonight with our featured speaker, Dr. Ana Contreras-Barocio. She is a board-certified sports medicine physician from the University of National Autónoma de Mexico, also known as UNAM. Dr. Contreras today will speak on rehabilitation post-repair from complete PCL ruptures. Dr. Contreras, could you please share your screen with us?
Yeah, sure, of course. I get started. Okay. Okay, so we're gonna talk about non-surgical management of PCL tears, but I'm gonna go over a lot of the important things that you should know first. I know probably most of you know what I'm gonna talk about, and this is super exciting. But let's go over the basics. Okay. So first, this is who I am. I'm a professor at the university here in Mexico. It's called Universidad Nacional Autónoma de México, which is the biggest public university we have here. I have the pleasure to work with residents from sports medicine. I graduated there of almost 2 years ago, and I have a lecture there called Comprehensive Diagnosis. So basically, what we do is go over a lot of information and all of from every lab that we have there. So all that information gets to the place where I am. I have the chance to analyze every little result or big result that we have from every lab, and actually, I give every patient the 101 things that they should know about all the tests they have. So basically, I have to interpret a lot of information. I also am an exercise specialist from a company here, well, there in the USA, it's called PrevMed Health. And what I do is basically program exercises for patients who have diabetes, who have had a heart attack, patients who have obesity, and a lot of other chronic degenerative type of diseases. And I also work at a clinic called FitMed here in Mexico City, basically doing rehab. So I have no conflicts of interest to disclose, and this is me. Basically, I love rugby. I know most of you like rugby by now. I love my dogs. Was my favorite dog, and that actually in the background is one of the main libraries that we have. It's kind of like humanity resource type of thing. So we're famous for that. But I wanted to show you that. And here's a picture of my team and my sister. She's the one who got me into rugby, so thank you her for that. Okay, so let's go to what we're gonna talk about today. So first, we're gonna go with a brief introduction. We are gonna talk about basic anatomy, but it's just really, really basic anatomy. After that, we're gonna go with we're gonna go with basics. So first introduction, second step's gonna be basic anatomy with some clinical maneuvers that I consider important for you. Imaging, I love that. That's super important for us now. And then we'll go to the real deal. What happens when we know someone has a PCL injury? So should they have surgery or not? Like, honestly, no one knows what's the best thing we could do for our patients. Okay, so we're going to talk a little bit more about that and what we know that could be better for our patients. After that, we're going to go for real life scenarios. So this all started because I had a couple of patients who had a PCL, they got their PCL torn while playing rugby. So we're gonna go with real life scenarios here, and then conclusions. Okay, so if anyone has any questions, just let me know, and I'll be glad to help you with that. Okay, so let's go with the introduction. So first, demographic data. So what happened here is that someone in Italy said like, okay, hey, something, we've got 15 years of information here about PCL, and what's happening to who's in risk, who's at risk of having an injury. So basically, what they found was what we already knew about some other type of populations. First, it happens in younger populations, somewhere between the 20s and 30 years old. Some of them, getting to the 35, 40 years old. It basically happens in male patients. And it has to do with the fact that they reported more and they played more sports before than what we do right now, females. But we know now that even though as females start, doing more sports and getting more into rugby, for example, there are more males having these types of injuries. So, what happens? So, like, are there any associated lesions or injuries? And actually, yes. isolated PCL injury is less than half of the injuries that we have when you're looking at PCL rupture. It usually goes with ACL injury, medial meniscus injury, particularly the posterior horn, sprain of any other type of ligaments here, like lateral collateral or medial collateral lesion, usually just sprains and not complete rupture. But you have to know that there are little patients that have just PCL injury, isolated PCL injury. So how does that happen? And I drew something here because usually it happens when a a player or a patient has their knee bended almost like 90 degrees or more than that with dorsiflexion of their ankle. And if they're carrying someone else along with them, then you have like a full blown injury to knee. So basically if you fall on your knees, you have the chance of having this type of injury. But this is not the main way of or the main way of getting that injury. Basically, it's with car accidents. Okay, so that's the number one cause of these types of injuries. But since we're talking sports, I would say any type of sports where there's contacts, let's say rugby, football, hockey, lacrosse, all of those sports where you could have, like this type of collision, could give you a PCL injury. Okay, so what about our patient? And I'm going to drop a little bit of information about her right now. So she's now a 30-year-old female. She was 28 when she had her injury. She has been playing rugby since she was 20 years old. She's a forward. As you know, forwards are basically up to number 8. So she plays as a tight head prop or a hooker. So she has a lot of contact every single game. Every single game, she has a lot of contact. She does a lot of tackling. But in this particular game, she was carrying the ball, and someone came from the backside of her right side, from the back, and they tackled her. She fell on her right knee. The knee was bended, and she had some extra weight in there. Okay, there was an adversary just on top of her, and she fell to her right knee. So what happened then is that she felt a lot of pain. It started to swell immediately, but she tried to walk and she was like, okay, yeah, I can walk. That's really good. I think I'm doing well. So I'm going to try and continue to play. However, when she started to run, she felt an unstable knee and that was it. Okay, so she was immediately taken out of the field. And at the moment, I was not the doctor, I was actually playing, but the doctor at the field said, like, hey, something, this looks like your ACL. It might be torn. After that, and we're going to take a look at maneuvers we're going to do for our patients. What we know was it was PCL and not ACL, but at the moment, it sounded like a possibility. Okay, but remember, this is how usually PCL gets torn. Okay, so that gave us a good idea of what might have happened. So what we did at the moment was price. We still use that. I know there's some controversy with ice, but that's another, like a completely other talk that we could have. But first, we had to protect, rest, ice, compress, and elevate that knee. So what we did in the moment, we had a brace there, we had some crutches. So there we were with rest, ice, compression, and elevation. So that was kind of like the first thing we did there. So now I'm gonna jump over to basic anatomy because I don't want to go deeper into what happened to her patient. We're gonna talk about that when we talk about how we actually got her back to her knees, well, to her feet, and playing rugby again. So with basic anatomy, we have 4 big ligaments here that we should be aware of. But there are a lot of other soft tissues in our knee, but we're gonna talk about just lateral collateral ligament, anterior cruciate ligament. We have the posterior cruciate ligament, and we have the medial collateral ligament as well. Of course, we've got the meniscus and we've got cartilage there. The important thing that you should know about PCL is that it's the strongest ligament, the strongest ligament in the knee. Okay, and it can take up as double as the tension that ACL can take. So basically, it can go somewhere between 739 newtons to 1,000 and a half newtons. That's a lot of energy that you can have, like it can uh, bear, and that's why it's kind of like the most strong or the most important ligament when it comes to TBL posterior draw. So basically, what it does, it stops tibia and femur from moving up and in forward and back. and it takes about 90% of the full range of motion from posterior draw. And one might think, okay, so what happens? And it kind of makes no sense. You're saying you can treat that without surgery, but it takes about 90% of the tibial posterior draw. Well, yes, but it's kind of like dazzling for everyone because yeah, even though it takes 90% of the full uh range of motion there, you can actually treat someone without surgery. And that's really, really cool because it gives us a lot of information about our knees. It's not just about how strong the ligament is, but how well our muscles and other soft tissues are working. So you need to know that it has a large cross-sectional area. And what's important here is that you have two bundles. And I'm going to put it this way. It's just a posterior medial bundle and anterior lateral bundle. Of course, we've got some other ligaments here that go towards the meniscus, but I'm not going to talk about them right now. Uh, but basically, just remember two bundles, anterolateral and posterior medial bundle. Okay, so here we have an artificial split between bundles, but usually they're like all torn, they're all put together and form this big and huge posterior cruciate ligament. So what you need to know about this is that if you take a look at the picture here, it says 12 o'clock, 7:30, and you've got a huge, huge place where it's like it's stuck there. So you have it's like a pretty wide insertion for the PCL, and that's what makes it strong. You have two bundles, but it's pretty wide open there. So you have the ability of getting to know what happens. So if you have two bundles there, you have anterolateral and posterior medial, and they change. They are not tied or relaxed at the same time. So during extension, our anterolateral bundle is completely relaxed. The posterior is kind of like just starting work, and the central part is the one that's more tight, where we have full extension. However, as we start to bend our knee and we get to 90 degrees, we've got ALB with fully tightens. And then as we pass 90 degrees to 120 degrees of flexion, we've got tighten our PMB or posterior medial bundle. So you can have an injury of just one of those bundles. However, they work together. And the most usual type of injury is a complete PCL getting torn. Okay, so that was just basic anatomy. I'm not going to go deeper into biomechanics because that would take a long, long time. But now let's move on to the maneuvers that we did to our patient, and maneuvers you want to experiment with when you have a patient and you suspect PCL. It's torn. So first, we've got the posterior drawer test with a high sensitivity and high specificity. So this is a really, really good test that you could do, and it's pretty simple. So I'm going to go ahead and just go with the video. And basically, what you have to do is ask your patient to lay down in a supine position. After that, you're going to get your fingers into your tibia. Make sure it's not up there, with the patella, because you're going to stop that motion, but you got to push back. And that is a positive test. Take a look at the tibia, how it is moving backwards from the femur. Okay, so let's take a look at that again. Okay, this lets me do that, and we will. Okay, so there you go. Remember, that's posterior drawer test, and you have to sit down in your patient's feet, actually, or foot, and then you're gonna push backwards, okay? It looks a lot like the anterior drawer test, and I'm sure all of you know what test is all about. It comes to ACL rupture, but basically we're pushing our tibia downwards and it's moving, okay? So this obviously is a positive test. So let's move on to the next test, which is called posterior sac sign, but we also have something called Godfrey sign. And basically what we're going to do is have our patient lying supine again. Knee is going to be bended at almost 90 degrees, a little bit more if possible. And there we're going to take a look at that test again. Okay, let me just make sure it will run. Okay, let me just try that again. Okay, here we go. So I'm gonna move it forward because I want you to take a look at this. Okay, same position, our patient is supine. Then we're gonna make our patient just lie there. And then we will take a look and we can even touch our tibia. Okay, so usually you can touch that tibia, the tubercle of a tibia, you can touch it. But in this case, since it's moving backwards, you won't be able to touch that, or you will feel like a little step going downward. So first you have your patient supine. Then you ask your patient to bend the knee at about 90 degrees. And in that position, you should be able to feel that tibia tuberculum. Okay, if you can't feel that, and if you can't see that, it's because the tibia is moving posteriorly. Okay, so that's a positive sign. Then we move to the Godfrey sign, and then you're going to ask your patient to get their knee bent at 90 degrees. You're going to take that ankle high, just as you were going to watch here in the video, just like that. Okay, you hold that ankle there, and the tibia is going to move down just because of gravity. Okay, there is no PCL holding that tibia there, so it's going to go down, and you're going to have a negative step. Okay, so those are two other good signs that you could use with some maneuvers to check on PCL. Basically, if you have a positive posterior draw test, you don't have to think a lot about some other things, but you can always check on those maneuvers. Okay, so that's the Godfrey sign. The PCL is torn, and gravity is just going to pull that down. Okay, so let's move into the next video, like the other test, which is reverse Lachman. I'm sure everyone here has heard of Lachman test. It's one of the best tests you can do to check an ACL. So reverse Lachman obviously goes for or PCL. So this has a really low sensitivity, but it has a kind of good specificity here. So you can always try that. But if you have two positive tests of the previous ones, you don't really have to go with Lachman. Okay, so you have your patient lying supine, just as if you were going to try a Lachman, like a normal Lachman, but instead of getting that tibia anteriorly, you're going to have to push that. Okay, so if you take a look at that, it goes backward, and if you have a positive drawer posterior test, then there's no doubt you have possibly, well, there's no doubt, there's doubt. You always need to do some imaging. Okay, and let's go down to the quads active test. This is a really nice test because you're gonna ask your patient to activate quadriceps here. And let me just get this going. Okay, now this won't work, but let me just try again. Okay, don't worry. What's gonna happen here is you're gonna be with your patient laying down. Again, your knee is gonna bend at 90 degrees, and you're gonna ask your patient to activate their quads. If they activate those quads and the PCL is torn, it's going to move backwards. Okay, TB is going to move backwards, and you're going to watch again that little step. Okay, so no worry, don't worry if that test is not working. So let's go. Oh, now it worked. Okay, again, patient supine. And if you ask the patient to activate quads, just as he's going to do here, you're going to notice how the TB is going to move. Okay, in a patient without PCL injury, you won't see that. Okay, activation of the quadriceps won't make your tibia move backwards, and that would be a negative test. In this case, that's a positive test with a really high specificity. Okay, sensitivity is really low, but again, specificity is good, so it kind of like goes into a positive kind of way. And then we have the prone dial test. And I don't know if you've heard of this, you probably have, but it's kind of like a non-well-defined structure in your knee called posterior lateral corner. And it's created by a lot of soft tissue around that side of our knee, but it's sometimes we forget that it exists. And a lot of patients that have ACL rupture, PCL rupture, don't get a lot of attention for posterior lateral corner. And that is important because when you have surgery for ACL or PCL and you don't take into account posterior lateral corner when it comes to imaging, you could have a rupture of every type of how to call it, of every type of graft that you've used before. So you definitely need to take a look at this. Okay, and this is a really easy test to go with. It's called dial test, and you have two options here. So with external rotation of your ankle, well, actually your feet, you will watch some angles here. So if the angle is less than 10, or no, sorry, more than 10 and less than 60, then you can think about just PCL rupture. If that angle is wider and you go more than 60 degrees of rotation, then you can think about PCL and posterior lateral corner injury. Okay, so I'm going to show you how that test works, and you can see what I'm talking about. So you have your patient prone, you ask him or her to bend their knees at 30 degrees, and then you make it at 90 degrees. Okay, so here it's at 30 degrees, and you do some external rotation. So you're watching that from above, and you're able to see that external rotation here. Okay, so if it's less than 10, maybe PCL is not completely broken or completely torn. If it's more than 10, PCL is definitely ruptured. And if it goes wider than 60 degrees, then think about posterior lateral corner injury. And remember, that's important because it's going to make our patient unstable, but it will also make grafts more prone to rupture or re-rupture. Okay. So then we'll go to imaging. Okay. And when it comes to imaging, we always think about MRI, but I'm going to tell you some news. Here at the university, it's a public university, and not every patient has a chance of having an MRI. So let's think simple and cheap. So first, always go with an X-ray. Okay, so it is always the first option for a lot of the injuries that we are coming across. So first, always check for a fracture. When it comes to high intensity types of injuries, you always have to discard the chances of having a fracture. So first, X-ray, pretty simple and pretty cheap. You can also take a look at soft tissue edema, indirectly, of course, and it's not going to give you a lot of information about other type of injuries. But if you see a lot of edema, then you say like, okay, there's a lot of edema here. The knee is looking really, really big. I might as well do an MRI. Tibial translation is key. Okay, that is one of the most important things you can measure with an X-ray. And the X-ray could be done with gravity as an ally, for example, as the first image up here at the right is showing. And you can also ask the patient to activate quads or hamstrings. That way, you can make sure how bad that translation is. So basically, here we have an image. It's a radiograph showing a measurement called Purdue, and it's a technique they use there. So basically, what you're going to do is measure the femoral condyles along the trochlea, and you're going to measure that against the anterior tibial plateau. And here you notice a difference of 6 millimeters. So that's showing us that there's translation of the right side, the tibia is moving posteriorly, and the left side is the uninjured side. Okay, so a difference of more than 4 to 6 millimeters gives us a positive test. If there's a difference of just 1 millimeter, that may be just an anatomic variation. Okay, so don't worry, don't panic if you see that. Okay, but then we have this other image. So we're looking at our leg from the side, okay? And you take those 3 lines. So you've got 2 perpendicular lines here at the left side. You take a look at this. Okay, let me just use my laser here. Okay, so you have them here, and you've got one horizontal line just here at the tibial plateau. Okay, and if you take a look at this here, it's wider than the right side. Okay, so then tibia is moving posteriorly, and we have another indirect data that that ligament is torn. Okay, so you've got imaging, but you've got the maneuvers, and you don't even have an MRI yet. And you can tell the patient, hey, you know something, just with that, we know that your PCL is torn. And in our case, we would ask an MRI, but it's not usually our first option because of cost. Okay, so remember, you have to adapt to whatever you have at hand. Then let's move forward to the classification of the injury. And this has to do with the fact that not all injuries are going to need surgery. A lot of them will, and some of them will need that, but patients don't have enough money to pay for that. So we need to work with what we have again. So grade 1, grade 2, and grade 3 for PCL. So basically, what you have to take into account is that if you have any PCL injury, and you have some other injury, that could be ACL, medial collateral, lateral collateral, meniscus, then it's already a grade 3 injury. Okay, no matter how little the damage is to PCL, if you have something else in there, it's going to be grade 3. Then you can divide into grade 1 and grade 2, which is partial or complete isolated tear. So if you have somewhere in between 1 and 5 millimeters, remember we've measured that before, then that's a posterior translation of the tibia, that's a partial tear. If you go somewhere between 6 and 10, but you don't have any associated injury, then you have a complete isolated PCL tear, and that will change, of course, the course of action, but it will change again risk factors for re-rupturing other the same ligament or other ligaments. Okay, so I know MRI is our best option, but why is that? Well, because you can check all ligaments, you can check other type of soft tissue, but remember that PCL alone is a rare pathology, so you should always look for something else, and that's why we like MRI. It is not the best test to check on bones, and for example, I've mentioned, if you remember, I've mentioned previously that you can also have a fracture associated with this type of injury, so this would not be our go-to option if we're thinking about that. But then again, you already had an X-ray, okay? And always, always take a look at the cartilage of the condyles and patella just to make sure you don't have anything else that could be important when it comes to surgery. Okay, so I know most of you have seen an MRI before, but this is just an example of what a normal MRI would look like. Okay, we take a look here. Obviously, here's the ACL, like in yellow, but just in background, we have the PCL. And if you take a look at that, it's kind of like a black tube. Okay, I want you to keep that image in your head. And we have the femur, we have the tibia, and we've got the patella as well, and we've got the patellar tendon right here. Okay, but I'm going to show you some other images that I loved. So this here, remember, MRI is like cutting bread. You can cut the bread in different positions, different angles. You can do cuts as wide or as as short as you want to have them. So here we have, what does a PCL, normal PCL, looks like. You take a look at this, it's kind of like a C-shaped kind of ligament. It's a black tube here, and some describe it as a hockey stick, okay, on the sagittal plane. So you have a hockey stick here, and you have a puck in the coronal plane. So you have it here, okay? So here's the puck and a hockey stick. And I hope you don't forget this because it's really helpful. If it looks like a hockey stick, then it's okay. But what happens, and I'm going to show you, this is a comparison of MRIs. So in the upper corner, left upper corner, we have a normal PCL. Okay, take a look at how black it is. Okay, it's like a complete black tube there. And you can take a look at the whole PCL. What's its insertion, proximal and distal insertion. So that is completely normal. Okay, if you take a look at the image down, left corner down, you don't see like that completely black structure that we had before. It's kind of like bended in between, kind of like just that whitish matter there. And that is a PCL that's not completely torn. That would be like a grade 1 lesion or injury of the PCL. And again, you can't see here at the corneal side that puck we were talking about, right? Then let's go to the right corner up here, and we don't have that black tube here, kind of like a C shape. But if you take a look at here, you also have an avulsion. Okay, so you have a fracture associated with that PCL rupture. Okay, and that's important because that there is an indication for surgical management. If you have an avulsion, you don't have the option to treat that without surgery. Okay, you need to do that, and you need to do that ASAP. Then we have G and H here down at the right side, in the corner, and you have this whitish matter here. That's just blood. Okay, that's just a lot of blood. There is a non-existent PCL, and that's a complete rupture of the PCL. You can't take a look at that and say like, hey, I see a hockey stick there, and I see a puck there. You can't see that. Okay, and maybe there's a lot of blood and that's impeding us from, seeing that PCL. But if you take a look at that without any blood in there, a couple of weeks after that, you will see the same thing. There's a non-existent PCL. And then this is the MRI from our patient. If you take a look at this, all those like red arrows, that's the place where the PCL should have been. It's not there. There's a non-existent PCL. There is no black tube in there. And well, here it is again. There is no PCL. Okay. What was important here was that her LCA was completely normal. If you take a look at that, that's a coronal cut of her knee, right? But here we have the whole LCA distal attachment, and it is okay. So everything's good. We don't have a LCA rupture here, which is pretty positive because if you have LCA plus PCL, that's another important thing to consider surgery. Okay, because that knee is going to be super unstable. Okay, and in this case, what I mentioned before is take a look at the condyles, take a look at the patella. She has a small lesion here, so that might cause her a little bit of problems later in life. And why is this important? Because one of the main problems that patients have when they don't have surgery is they have knee problems when they get older. And it's not for certain that's going to happen to everyone who goes into a non-surgical approach, but it happens more frequently. Okay, so I'm going to translate this. Basically, this is what the doctor said. So she has an acute complete traumatic rupture of her PCL right in the middle. With basically, that's it. She has a small lesion on her medial meniscus. That's grade 1. It's affecting the posterior horn. Remember, that's the meniscus that we talked about previously. This is common. She has patellar chondrosis grade 2. That's what we mentioned. You should take a look into your whole MRI. And she has a little injury. She has the grade 1 injury of her collateral lateral ligament. So now we know that she has a grade 3 injury. Okay? And why was that? Remember, if there's any associated injury other than PCL rupture, then that's immediately a grade 3. Okay? So what happened now with surgical versus non-surgical treatment? Okay, if you take a look at, if you want to go ahead and jump into a lot of reading, you will find there are a lot of reviews. We don't have a lot of meta-analysis. We don't have an umbrella analysis of that. We just have a lot of reviews. And what we did have later was a Delphi study. And they took I would say were like 50 to 60 experts that did a lot of surgery of PCL. They came up together and came up with a consensus. But remember, expert consensus is not the best type of evidence that we have, but it is what it is. It is what we have when it comes to PCL because of 100 injuries of the knee, just 2 injuries are PCL. Okay? So we don't have a lot of information. We don't have thousands of patients getting surgery just as it happens with ACL. So what happens? So what am I going to do? I'm the doctor. I don't have a lot of good, positive information coming from, the best sources possible. So what am I going to do? And that's a really good question. You have to individualize with every patient that you have. And it's not just about imaging. It's not just about how much of discrepancy I have when it comes to posterior movements, from tibia. It has to do with the fact that they are doing great with their gym training, they're doing great with symptoms, you don't have swelling. So uh, I had this image here because I wanted to make sure you understand that, and I'm sure you do. Medicine is not about black and white. That does not exist in medicine. It's not all good, it's not all bad. We've got this kind of gray area here, and we don't just have 2 options. First option would be to not get everyone into surgery. No one goes to surgery except for the person who has an avulsion. But what happens with complex situations, just this ACL plus PCL rupture? So should I say that not everyone's supposed to have a surgery, or no one's going to have a surgery? That's just going into this white side, for example. What happens if I have an unstable test? I have instability. My patient says that, okay, I've done a lot of exercise, I go to the gym, I've worn my brace for a long time, but when I start running, I feel unstable. Should we just consider non-surgical management? Or what happens if the patient feels well, they go to the gym, they have a super cool kind of like strength training program, but imaging says they have a lot of movement of that tibia over femur. So what happens then? As I've mentioned, you can't work on white and black. You know, it's kind of like working in that grayish area in between. And our second option would be operate everyone. Everyone goes into surgery. But what happens if my patient has no instability symptoms? No, they jump, they run, they tackle, they turn, they do everything good, and they feel good. Are we still going to make them go into surgery? Have a surgery where they're going to have to take a graft? Because those grafts work better. You can have one bundle or two bundles. Usually the best is two bundles because it looks more like the, native PCL. But really, if they're doing really good, why am I going to put them through surgery? It's going to take at least 1 year to get back to, to usual routine in sports. So if they're doing great without that surgery and they don't have instability and they feel great, that knee is not swelling, it's not swelling a lot, image looks good, why should I go for surgical option? So at the end of the day, this is one of the best things that someone come up with. And this is the best algorithm that I came across, and I want to review this with you. So we have PCL injury, and we've got acute and chronic. We've got patients who never knew they had PCL rupture. They've been playing like that for years and years and years, and out of the blue, they have, like a blunt, like injury to the knee that had nothing to do with PCL. And then you review the test, you go imaging, you go do some images, and you go review them, and you do some maneuvers, and you say like, hey, you know something? That PCL is torn. Didn't you notice anything? And they were like, no, something like a few years ago, it kind of like, I had a, like a bad blunt, like a blunt, like injury. I don't know, it kind of hurt for a while, but after, going to the gym, everything was okay. So then you have that option of chronic PCL injury. Then you have to do some imaging and make sure it's just isolated or multi-ligament lesions. As we've mentioned before, if it's multi-ligament lesions, our best option is to have surgery. And why is that? Because that's an unstable knee. If you're looked at from different sides, if it's collateral, medial, if it's PCL, but you have several ligaments involved, then surgery would be recommended. If you have an isolated injury and you don't have instability of that knee, and you do a lot of tests, you do one side tests with both of the legs, and you have isokinetic tests, and you have good strength there, you have less than 90% of variability in between the legs, they don't need surgery. They will do good with just like conservative management. But what happens with acute injury, which is something that I take a look at a lot, and as I've mentioned, just about two or three injuries of PCL or watch for every 100 injuries of the knee. And I have three of them. So I think I'm the bad luck there. But anyway, I had them, so I had to study a lot about it. So first, acute PCL injury. So what are we going to take a look at first? Okay, is it isolated or is it combined injury? As we've mentioned before, if it's combined injury and it involves ACL, MCL, or meniscus, for most patients, we're gonna need surgery. In the case of our patients, she didn't, or the patient that we treated first, she didn't want to go over surgery because it would have taken 1 year for her to get back. While doing conservative treatment, we got her playing in about 15 weeks. I know it was kind of, like it was quick, but she wanted to go and play at an international tournament. It was planned a year before her injury. So again, remember, you're treating patients, you're treating their dreams, you're treating what's important for them. It's not just imaging. Okay, so what they have to say is important. And what medicine is moving forward is shared decision. So her decision in her case was to move forward with conservative treatment. Okay, but remember, this is just a guideline. You have to use your brain and you have to use your sense of, okay, what's good, what's not, what could happen, what could not, and make sure the patient understands all of that. She knows she might have some damage in the long term, but she wanted to go that way. She knew that she might have surgery at some point, but she wanted to play. So we went ahead and started with just conservative treatment. Okay, so just go ahead and take a look at this algorithm. I think it's one of the best that you can find out there, and I'll be glad to lend you all the scientific papers that I have here. Okay, so if you want to have them, I can send them over, and you can take a look at what I'm saying. Don't believe everything I'm saying. Go ahead and read. Always question what everyone says. Okay, so let's move forward to real life and conservative management. So what we've done with them, as I've mentioned before, she had a grade 3 injury. She had to have surgery, but she didn't want to have that. And with the other patient that I have, she had just a PCL injury, no other ligaments involved, but she had a lot of instability. However, due to money constraints, she wasn't able to have surgery, so we treated that conservative. Okay, so remember, there's a lot of factors involved. So basically, it looks a lot like an ACL scenario. It looks a lot like that. However, when you're treating ACL patients who had a reconstruction, you have to take into account what type of graft they used and if they had any associated injuries. But if let's assume it was just ACL, and you have two different like pathways here. So if they use hamstrings or if they use tendons, patellar tendon, then you have different advantages and disadvantages. In this case, just remember that our biggest disadvantage is that that tibia is going to move posteriorly. Okay, so in the first stages, we can't work or shouldn't work a lot on hamstrings, calves, and basically gastrocnemius, and that's it. Okay, that's like the most important thing you should know about this. Our patient's going to need a brace, and there are some specific braces intended for PCL getting torn. So take a look at this part here in the back. Okay, if you've ever watched someone wearing an ACL brace, it does not have this here. And why is that there? Because it's impeding tibia from moving posteriorly. And that's why this brace is going to be really important. So the range of motion for the first stages, I'm going to go ahead and say like, okay, there are some weeks that we could consider, but remember, time is not the most important thing here. You need to think about steps that the patient needs to have in order to move forward. So first, gait. Gait is super important. We need to make it as normal as possible, as quickly as possible. For someone to be able to have a normal gait, they need to gain extension. And since there was a rupture there, that knee is going to get swollen. Okay, so first thing, control how swollen that knee is, control pain. That's going to be so important for the patients. Make sure they have appropriate quadriceps activation, especially with isometric exercises. Okay, that's going to be key for them to get moving more in the first couple of weeks. That's going to be stage 1 and part of stage 2. Okay, so remember, range of motion here should be 0 to 90. Once our patient gets to 90 degrees of motion, we can start doing some other exercises. But this is like the first steps that you need to take. Okay, and remember that brace is going to be so important. In the case of our patient, if you remember the interpretation that the imaging group did, is that it was torn right in the middle. And you have a little piece up here and a little piece down there. And at some point, since PCL has more vascularity than ACL, it tends to heal better. So at some point, just keeping those two pieces of the PCL together or as close as possible would have been positive. And that's the reason why we recommend for our patients to use a brace. Remember, the brace should be blocked at 0 of extension. You shouldn't block that to 90 degrees of flexion because it's going to be hard for them, but at least for the first few days, just lock it from 0 to 90 and make sure they're moving as much as possible. Okay, there is no counterindication for them to hit the gym. and work with the leg that's not injured. If you take a look at, the most recent evidence, if you start working with the leg that's not injured, you will have more chances of decreasing the time the leg injured is not moving. Okay, so just let them go to the gym and do some leg extensions, some curl for the legs. At some point, not the first couple of weeks, but the third or fourth week, you can go to the gym and do, work on your abductors and adductors. And it's okay. You can work with your abdomen, your chest, your shoulders. Everything's okay. It was just PCL. Okay. And that's going to make your patient feel like they can do a lot of things. So when it comes to psychology, that also helps. Okay. So stage two, it looks a lot like stage one. Stage one is basically just controlling edema and controlling pain. But when it comes to stage three, and this is really important, you have to start discharge crutches. Okay, so in order for someone to walk appropriately, they have to have a range of motion that goes from 0 to 130 degrees. Again, you're gonna continue to use that brace that we talked about before. However, you can start with a normal gait, okay, without crutches. It could take up to 4 weeks to, clean or get out of crutches at all, but it could take more for some other patients. Remember, making them feel safe is always important. Something that could help, and not everyone has the chance of using, an anti-gravitational treadmill. That'd be awesome, but not everyone has it. If you have a pool available, works the same way basically. Okay? Water walking or anti-gravitational treadmill is gonna help your patient feel better. They can walk, but you're not putting all their weight into that need. It's kind of sensitive at the point. Okay. Once you have a full range of motion from 0 to 130, you can start doing a leg press. Okay, because they will be working in their quads, a little bit of the hamstrings, but basically quads. And that's the muscle that we care about the most when it comes to PCL rupture and conservative treatment. Remember, quads is pulling anteriorly and PCL pulls posteriorly. Okay, the PCL rupture is getting your TB to move posteriorly. So we need you working on those quads as much as possible. Okay. Other important exercises, you can start doing unilateral support and working a little bit on progressions towards working on balance and proprioception. Okay. But the most important thing here is that just as it happens with ACL, it's not a linear kind of pathway. It goes up, it goes down, you come back, it gets swollen, it hurts, and patients get discouraged. So what you have to do is basically go slow and steady, making sure they are getting the full range of motion and they are activating quads. Okay, you will start a step down program. If you've ever had an injury like that, you will notice that when you go down the stairs, that PCL or ACL moves. TV is moving and femur is moving, so that gives a sense of instability. And you need to work towards decreasing that, gaining muscle mass, especially quads, and making sure that patient is doing progressions. So first, start with a 5 centimeter step. Sounds like it's not a lot, but for a patient who has a PCL rupture, it's a lot. Trust me, you need to work unilateral support and step down program, and you can start with mini squats. You can start squatting from 0 to 30 degrees. You can do that on a wall. There's a lot of things you can do. And this is just an example of an anti-gravitational uh, treadmill. So if you've never seen one before, this is it. So basically, it's like it's a vacuum, okay? And it's taking your weight apart. You can actually manage that from 0 to 100% of your weight. You can choose how hard you want to go. But at first, remember what you want to make the patient feels like they can walk again, a normalized gait. So you will start with an 80 to 90% of their without their weight, and then move forward to 0 or 10% of their weight as they move forward. Okay, so this is another good option for your patients. Okay, moving forward. Okay, okay, to stage 4 and stage 5. So stage 4 and stage 5, when we talk about timing, this happens usually at about 24 to, yeah, like 20 to 24 weeks after the injury. I know it sounds like a long time. It is, but it is longer if you have a surgery. So with our patients, this was something that happened. It was important. So by stage 4, gait was completely normal. That was really good. And then we could start with squatting. Remember, we wanted to work on quadriceps. Quadriceps is, pulling forward while PCL is not there and that is moving posteriorly. So leg press from 0 to 90 degrees at some point between stage 4 and stage 5 at about 20 to 21 weeks, you can start working towards increasing those rates with the leg press and squatting. What's important is that for you to get moving into running, for example, if you take a look at the ACL guidelines, you should have at least 80% of the same strength that you have with your uninjured leg. So how do we measure that? There are a lot of ways to do that. I've added one extra slide just to talk about that. But remember, you need to get that body really, really strong. You need to work on that leg getting super, super strong. And what we've seen before, and well, I will talk about it later. Don't worry. You can start eccentric exercises. At some point, we thought that at first it was not the most appropriate thing to do. We know now that you could work with some eccentric exercises, just as stationary bike going backwards, for example, that could work. And you can start here with some agility exercises, something that looks a lot like the sport your patient does. Okay, so in our case, we started, running a little bit forward, backwards without any changes of direction here, and like doing some passes with the rugby ball. That was good because patients want to come back with their team. Patients want to be there. They want to train. They want to feel part of the team. So it's important that you take all of those exercises you were doing before in therapy and move them towards the field. Okay, and adding sport specific movements is important. Stage 5 is basically working on details with quadriceps and hamstring specific details or deficits. And how am I going to measure that? Well, our gold standard is the isokinetic machine. I know some of you have heard of that. Some of you have used one before or know how to use it. But basically, what we're measuring is angular velocity or speed. Okay, so it measures how hard and how strong you are at different speed. So it's 60 degrees, 300 degrees, and 180 degrees. Okay, so basically what you do is, okay, you move pretty quickly. So if you're moving quickly, you're moving less weight. If you move, in slower speeds, you're moving more weight. Basically, that's how isokinetic machine works. So what we do is compare one leg to the other. And we would love to compare quadriceps against hamstrings. There's a good relationship here. And if you have a relationship of about 2 to 1, quadriceps being stronger than hamstrings, it's kind of like a safety valve. Okay, and you have less chances of having an ACL rupture, PCL rupture, or if you had any surgery, you have less chances of having the same injury or the contralateral injury of the same ligament. It works basically the same way for ACL and PCL, although we're not 100% certain for PCL. Okay, we lack information, but we're just extrapolating information from ACL. So you need to work with your quads. Okay, so make sure that when you're ready to go to stage 5, which is returning to your sport, returning to training, you have to have a deficit of less than 10%. Okay. You have to have a difference of less than 10% in between right leg and left leg. They have to look a lot like each one to each other. Okay. And when it comes to hamstring and quads, you have to have at least 60% of the strength you have in your quadriceps in your hamstring. Okay. That's going to reduce the chances of having another rupture or the same rupture again. You can always use a handheld dynamometer. It's not the best option, but it's cheap and you can use that. And remember, we're looking at deficits that are less than 10% in between the legs. Other tests that you could perform or 1 RM knee extension at the machine from 90 to 45 degrees. You could also work with 1 RM leg press and single leg, of course, and single leg extension machine. You can always try those alternatives. I mean, it's not our gold standard, but isokinetic machines are expensive and not everyone has one available. So remember, we have other ways of measuring our patient's progress. And just make sure when you're testing this, they don't have any swelling and they don't have a lot of pain. Okay? So jumping to conclusions. So should I like make everyone have a surgery? No. Honestly, no. You just have to consider what's happening with your patient. What if they don't have enough money? They don't have an insurance that covers that. Are you going to tell them that they can't go back to their sport because they didn't have surgery? I think that would be unfair, right? You would at least need to try conservative treatment before. And if they don't get to those landmarks, then you might tell the patient, hey, something we've tried for 6 months, 7 months, 8 months, you still have instability, you don't have enough strength, uh, maybe you actually need surgery. Okay, but we've tried before. They've had enough time to save for their surgery, for example. That happened with the other patient. So what about lack of stability as a factor to consider surgery or not? So basically, what the text says and what we know, from different papers is that instability alone is not as important as we thought it was. When you compare patients that did non-surgical treatment against surgical treatment, some patients with surgical treatment tend to have more instability than patients that didn't go through surgery. Okay, so that's definitely not the only thing you should consider to let someone play without having surgery. How long do I have to wait to return to my sport? It depends on the sport. When it comes to contact sport, usually we recommend about 6 to 8 months at least. Some patients have to go through a year without playing and just getting stronger and stronger every day. But if you play, for example, I don't know, what about if it was just racing? I did 100 meters flat, but I had an injury because I was walking my dog and I tore my PCL. Should I wait that long? Probably not. You will probably be back, ahead of time compared to someone playing football, rugby, or hockey. Remember, individualize. Every patient is different. Some patients want to have surgery even though they don't actually need that. Like, okay, you have a partial rupture, you don't play contact sport, but they don't feel comfortable with the whole instability. They feel unsafe. They feel like they might not get to their prior level of, how well they were playing before. So maybe consider surgery. At the end of the day, um, I don't know if you like Star Wars, but basically we're Yoda, okay? The patients look Skywalker, and we're just letting them know what our experience is, what we think, but their decision is final, and you just have to walk with them, okay? So basically, just go be Yoda and help the patient by letting them know what you already know, what you've studied, but at the end of the day, it's what they want to do is what they will do. Okay, so important things, we don't know everything about PCL. As I've mentioned throughout, today's meeting, we don't have a lot of information or really high quality information. We have some of that, but we don't have an umbrella type of test. We don't have, meta-analysis saying, hey, this is the best thing you could do for a patient with this characteristics. So basically, just go ahead and do some imaging, some tests, take them to the field and make sure, they don't have a lot of instability. If they don't, maybe try conservative treatment first. And with active individuals, some of the guidelines say that if you have a patient who is a athlete that's kind of competing, world-class athlete, they should all have surgery. However, we don't really know. We don't have a lot of patients that look like that. So you might want to just consider that in case you have, high-level athletes, maybe surgery at first would be the best option. And basically, that's the end of today's presentation. If you have any questions, go ahead. If you don't, it's okay. Here's my email. If you have any questions, you can find me on Instagram, just like that. I put some interesting things there. But if you have, any questions, if you want to talk more about something else, you can always send me an email and I'll be glad to help. Also, if anyone is interested in, doing a rotation here or a trip to Mexico City, you can always talk to me and we can talk to the person who's in charge of, the whole mobility, like students. And maybe that's an option for some of you. Okay, so you're all welcome if you want to ever come to Universidad Nacional Autónoma de México.
Thank you for that excellent presentation. So, are there any questions, or Dr. Lopez, do you have anything to add?
Hi, good evening. I just want to say thank you so much for that insightful presentation. I think that especially the illustrations and the more comparisons you make really help highlight the topic and make it a lot more digestible for us to understand. I just had a quick question
Sure.
regarding, I guess, combating kind of muscle atrophy
Okay.
in patients. Just more so after someone doesn't use their injured knee as much, the muscles will probably shrink over time as compared to the uninjured one. So in terms of combating that, I know blood flow restriction therapy is a popular option here. Do you know of any other treatments that could help combat that, or essentially, I guess, allow both knees to be back to the same performance?
Okay, yeah, that's a really good question. So yes, flow of blood restriction has been used in ACL treatment before. We use it a lot, and apparently it could be used with PCL. Basically, the principle is the same. We want to prevent that muscle loss. Okay, so blood flow restriction could be really useful. And have you ever used a complex device, or have you ever seen one of those, like electrostimulation?
Probably not, no.
Okay, so you have four patches that you attach to the quads. And actually what you do is you start using electrostimulation at the same time as you're doing exercise. So you can do isometric exercises along with that type of therapy, and that's going to help you increase muscle mass and muscle activation. There's this, it's kind of beautiful and bad at the same time. But your brain, when it senses that you have an injury, stops your muscles from working out. It's like you're telling your brain's telling your muscle to move, but it won't move. And that's well described in literature. So you have to go through all that process to make sure you're getting that signal again. And especially with blood flow restriction, but with the whole electrostimulation type of therapy, you can jump out of that place where you're not moving. You're giving the direction from your brain, but your muscles not moving. You can make that quicker. So that those two could be really good options to stop muscle from like wearing, and using the contralateral muscle. So if you have, for example, you're not using your quads because you had an injury in your left side, go ahead, hit the gym and do some leg extensions with your right side knee. That's gonna definitely help.
Thank you so much.
Sure.
Hey, Dr. Contreras, thank you for that presentation. I found it really helpful how you did the anatomy part first because sometimes I get confused between the different ligaments and breaking down the PCL, the ACL, and different tests. It helped us really understand, or helped me really understand, I guess, how things work and what would happen if it does get injured. My question is more about the preventative side. Obviously, in
Yeah.
sports, there are things that happen, but if we have athletes, what would you recommend they could do to, I guess, be stronger or more resilient to injuries? I was thinking if there's like maybe any strength standards or maybe any mobility or flexibility standards that you would recommend for athletes to maintain. Something I sometimes hear is like a 1.5 times body squat, things like that. I mean, weighted squat, but I'm not sure if there's anything that you've seen that you would actually recommend.
Okay, so that's a really good question. There's not a specific protocol. However, something that we've been following in the past few years at the university is there's this really impressive scientific paper they did on rugby, just specifically on rugby. I don't have a lot of experience in other sports, but with rugby, it looks a lot like soccer, for example, or American football. So that's good. Um, there's there's this chart where you're using speed and strength at the same time. And it's basically the more strength you're using, the slower you get. And the more speed you have, the less strength you're using. So what you have to do is first measure that with a simple test. there's an app called My Jump. If you ever want to download that and start, like going over all of the tests that you could do there. Basically, what you do is measure how fast you move and how hard or how much weight you can move and how fast you can do that. Once that you've managed to actually get a point where, okay, I have an athlete who is super strong, but he's super slow. So what should I work on? Speed. And you work towards, increasing speed for them. You have a super, super like Speedy Gonzalez type of athlete, but he's way too, I don't know, he's not strong enough. Then you need to work with him or her towards getting stronger. You have a perfect kind of line that goes all the way in diagonal, where you have the perfect athlete that's moving fast, but he's strong enough. So I would say test them. Test your patients. If you have an isokinetic machine, go ahead and test them. If you don't, go ahead and, I know there are a lot of tests, like a one side jump and then try the other leg, and they should be as similar as possible. So that ratio that I mentioned before, that had to do with hamstrings and quads, being 60% of the strength that you have with your quads for your hamstrings, that's going to prevent injuries. Yes or yes. There's no doubt about that. And if you have good mobility of your hips, which sometimes we neglect, that could also decrease the amount of injuries you have. But basically, that's it. If you're interested in decreasing ACL rupture, for example, which could of course be used for PCL, there's a program called 11 FIFA 11, and they have this specific group of exercises intended for, it's first for soccer, but they've been used before for rugby. So you could also try some of those exercises. It comes back to strength, proprioception, and balance, basically.
Thank you.
Yeah, my pleasure.
Hey, Dr. Contreras. This isn't a question, maybe just a comment. I really did like how you had like all like the descriptive pictures and videos. I feel like it really helps seeing like it actually happen like while I'm in the call. That really helps me like really like truly look at it and see how I can apply it to like my daily life. So thank you for that. Are there any more questions?
Oh, my pleasure.
Thank you so much. That was a great presentation. It was very concise about what's going on with I guess, the pathology overall. More importantly, I think the only thing I'd actually comment on is maybe for everyone to understand is that the complications with non-surgical procedures, I apologize, non-surgical patients, is that there are quite a few complications: stiffness, persistent pain. There are things that unfortunately surgery can't fix. And I think that's the big problem with PCL. Maybe if you can elaborate on that, please, doctor, that would be something that maybe everyone can understand. Because you're
Yeah,
leaving it
sure.
injured and you're hoping that it gets better. I guess that's the best thing I could say.
Yeah, so it's kind of like a tear and wear, like when you don't have surgery, that whole joint is not working the way it should. You tend to have more valgus, for example, of the knee, so that's going to put more pressure into the medial side. You could have some meniscus injury that you didn't have before. Of course, there'll be tear of the whole joint, for example. So in the long term, that might not be as positive. So you might have patients of 45 to 60 years old just like ready to have a full, joint replacement. So that's not positive, of course, because if we're expecting them to live 80 years old, they might have to have, a new like joint again. So they will be there for 2 or 3 surgeries. So yeah, I'm not saying it's like the only option that we have, the non-surgical. If it was me, I would have had surgery. Okay, especially for a grade 3. I would have had surgery. The thing here is that there are not a lot of expert surgeons doing PCL repairs. So that's something else you need to have, in mind. Okay, I need to know someone who's an expert in PCL because I'm going to send the patients that I'm going to, they need surgery. I need to have someone who has, I trust, 100% to do those types of surgery. Important things there with surgery, I think Dr. Lopez knows more than me of that, is that it depends on the bundle and the type of surgery. There are basically two different options here. You can have like something that they call like the how to put it, like it's a risky type of bend that new PCL has, and it could have another rupture. So as you've mentioned before, it's neither the solution one or the other. You have to, like play a little bit with both sides. Like, okay, what if it's surgical? What if not? What type of surgery are we gonna do? And obviously, if you don't have surgery, you might have in the long term some type of pathology with holding you, right? Especially kind of like wear off of the joint. And in the long term, maybe you will need like a knee replacement. So it's not as easy as saying like, yeah, I'm not gonna have surgery just like that.
No, we understand, and I appreciate you clarifying a little bit more of that. I think the big issue, as I was stating, is that do understand, right? If you do have a PCL injury and you do treat it conservatively, non-surgically, there still are potential for nags, and the issue is that due to the fact of the amount of use of the knee joint, there is a potential to have stiffness, chronic pain, synovitis, things of that nature.
Yes, of course.
And these things occur in any of the joints. That's what everyone should be really aware of. It's just a little bit more impacting when you can't walk.
Yeah, sure. Of course. It's like, okay, I can't walk, like what next? Okay. But it happens with every joint you don't have a surgery on and you try to treat that conservatively. I mean, you can, and sometimes it goes, everything goes smoothly and everyone's is happy, but sometimes they don't. They don't are as happy as they thought they would be.
No, I appreciate that out expanding on that as well. And thank you for giving us this talk.
No, it was my pleasure. And you have my email now. If anyone has any questions, just let me know.
That will conclude week 7 of the Rugby Research and Intervention Group Summer Lecture Series. We'd like to give a big thanks to Dr. Contreras for joining us today and everyone in the audience in attendance. Thank you all for attending.